Class today is on corticosteroids. Conventionally, by corticosteroids we mean glucocorticoids and mineralocorticoids. From which gland the corticosteroids are released and synthesized and released? Anyone? From which gland in the body corticosteroids are released or synthesized? Anyone? From which gland in the body corticosteroids are synthesized and released? From which gland in the body corticosteroids are synthesized and released? It's adrenal gland. We all know that adrenal gland has got two parts, adrenal cortex and adrenal medulla. Now adrenal cortex is again made up of, from outside to inside, zona glomerulosa, zona fasciculata and zona reticularis. This zona glomerulosa is responsible for the synthesis of mineralocorticoids, and zona fasciculata is responsible for the synthesis of glucocorticoids, and zona reticularis are responsible for the synthesis of sex steroids. Now, by this corticosteroid, we conventionally mean only glucocorticoids and mineralocorticoids. Okay. Now, the adrenal cortex secretes steroidal hormones which have glucocorticoid, mineralocorticoid and weakly androgenic activities. Conventionally, the term include natural gluco and mineralocorticoids and their synthetic analogues. Now, how they are synthesized in the adrenal gland? They are synthesized from the cholesterol. Cholesterol is taken up by the adrenal gland, converted to pregnenolone, and further they are steps take place and steroids are synthesized. Now, these corticoids are 21 carbon compounds having a cyclopentanoperhydrophenanthrin nucleus. This is a phenanthrin nucleus and here the cyclopentan ring is attached. This is cyclopentanoperhydrophenanthrin ring. Now, adrenal gland steroid synthesis, they occur under the influence of ACTH, adrenocorticotropic hormone released from the pituitary gland. Now, since adrenal cortical cells store only minute quantity of hormones, rate of release of the hormones are governed by the rate of biosynthesis. Now, the circulating corticosteroids, by the negative feedback mechanism, they inhibit the release of CRH from the hypothalamus and release of ACTH from the pituitary gland. The normal rate of what are the two endogenous corticosteroids released in the body? These are hydrocortisone, that is glucocorticoid, and the number 2 is aldosterone, which is a mineralocorticoid. Now, hydrocortisone 10 to 20 milligram is released daily. Nearly half of this in the morning few hours. So, more of the cortisol is in the morning than in the evening. That is the physiological cortisol level. Aldosterone 0.125 milligram daily is released. Cholesterol converted to pregnenolone, then they are diverted by, there are three pathways. They may be converted to progesterone and finally to the aldosterone. These are mineralocorticoid synthesis pathway. Pregnenolone can be converted to 17-alpha hydroxypregnenolone, finally to hydrocortisone, having both glucocorticoid and mineralocorticoid activity, and pregnenolone can be converted to testosterone, that is androgen or sex steroid. Now, coming to the action, these corticosteroids have got widespread action. Mineralocorticoids, they are responsible for the fluid and electrolyte balance, while glucocorticoids, their more action is towards the glucose, protein and fat metabolism. These corticosteroids, particularly the glucocorticoids, they prepare the body to withstand effects of all types of noxious stimuli and stress. In any type of stress, the stress they basically stimulate the higher centers that causes positive feedback, basically that causes increased release of CRH from the hypothalamus and ACTH from the pituitary, so that more of the corticosteroids are released in the body under the influence of stress. And again, this stress they basically stimulate the adrenal medulla, so that more of adrenaline are released. Now, corticoids or corticosteroids can have direct action, can have permissive action. What do we mean by permissive action? In permissive action, corticosteroids does not act directly, but they facilitate the action of other hormones. Like corticosteroids, they have got no action on blood pressure, but it promote or facilitate the action of adrenaline and angiotensin, so that there is increase in blood pressure. Action of corticosteroids can be divided into glucocorticoid and mineralocorticoid actions. Coming to glucocorticoid effect is mainly on the carbohydrate, protein and fat metabolism. Mineralocorticoid effect is mainly on the sodium, potassium and fluid balance. Coming to the mineralocorticoid action. Now they primarily increase the fluid in the body, and so they cause sodium and water retention. Now they basically enhance the sodium reabsorption by acting on the renal epithelial sodium channels located in the distal convoluted tubule. They enhance the sodium absorption. There is associated increase in potassium excretion and increase in hydrogen excretion, H plus excretion. Now what happens when there is deficiency of mineralocorticoid? When there is deficiency of mineralocorticoid, this sodium reabsorption from the renal epithelial sodium cells is decreased. There is increased sodium excretion. Now increased sodium excretion, what will it cause? It will cause decreased sodium in the body, extracellular fluid depletion occurs. Now to maintain that, there is more of water absorption from the renal tubules. As a result, there is dilutional hyponatremia. Now again, due to increase in water, this water reabsorbed in the body, more of it goes to the is taken up by the cell to maintain the cellular hydration. So the extracellular fluid volume, so the blood volume is decreased, leading to raised hematocrit. Also hypokalemia and metabolic acidosis, metabolic alkalosis is noted. So what is happening in the mineralocorticoid deficiency? There is dilutional hyponatremia. Number 1, there is raised hematocrit, and number 3, there is hyperkalemia, and finally acidosis. This distortion of fluid and electrolyte balance progress. As this condition is progressed, it ultimately leads to circulatory collapse, and hence mineralocorticoid action is essential for the survival. Now this action of mineralocorticoid, it is exerted by gene mediated mRNA synthesis in the renal tubular cells with direct synthesis of proteins, that is aldosterone induced proteins. Now what does it cause? Aldosterone induced proteins, basically we know in the renal basolateral membrane there is sodium potassium ATPase pump, which regulate the balance of the fluid and electrolyte within the renal epithelial cells. Now this is one of the target of AIP, aldosterone induced protein. Again, this AIP is responsible for the synthesis of beta subunit of the renal sodium epithelial cells, and also this AIP causes phosphorylation and activation of amyloid sensitive sodium channels. Amyloid ta ki ache? Amyloid, potassium sparing diuretic. They are acting on the renal epithelial sodium channels. Now What is the main adverse effect of excess mineralocorticoid action? It is fluid retention and hypertension. Also, we know these glucocorticoids have got associated mineralocorticoids, some of them. Some of the natural glucocorticoid, that is hydrocortisone, and some of the synthetic glucocorticoid, they have got associated mineralocorticoid action, and hence their use lead to side effects like edema, progressive rise in blood pressure, hypokalemia and alkalosis. Aldosterone has also been linked to cardiac remodeling, leading to myocardial fibrosis and progression of the disease. Now coming to glucocorticoid action, number one, carbohydrate and protein metabolism. Now in liver, glucocorticoid, they increase the deposition of the glycogen, number one thing. Number two, they increase gluconeogenesis from the, that is increased glucose synthesis from the amino acid. In the peripheral tissue like muscles, they increase the breakdown of the glycogen so that more of the glucose is poured in the circulation. So because of gluconeogenesis and because of the increased glycogen breakdown in the muscle, hyperglycemia occurs, insulin resistance is developed, and a diabetes like state occurs. Now coming to protein metabolism, these glucocorticoids, they are catabolic hormones, that is, they are responsible for breakdown of protein, leading to formation of amino acids. Now again, these amino acids are taken up by the liver to form for neoglucogenesis. Now because of the protein breakdown, there is muscle wasting, number one, there is lympholysis, there is loss of osteoid formation in the bone and thinning of the skin. Again, as the protein amino acids are taken up by the liver for neoglucogenesis, there is increased urea formation, so there is negative nitrogen balance. Now, we know glucocorticoids are now catabolic and they help in the maintenance of the blood sugar even in starvation stage by neoglucogenesis and by glycogen breakdown in the muscle, so that brain continues to get its nutrient, that is glucose. Glucocorticoids also increase uric acid excretion. Coming to the fat metabolism, now this action on the fat is basically permissive. It does not act directly, but it increases or facilitates the action of glucagon, growth hormone, adrenaline and thyroxine. As it is catabolic, it increases the breakdown of the lipid or promote lipolysis. It enhances the metabolism of triglyceride, and very important, it causes redistribution of fat in the body. Due to the muscle wasting, it causes redistribution of body fat in the body, leading to the muscle wasting in the periphery and muscle deposition in the face, neck and the shoulder, leading to the formation of moon faces, fish mouth and buffalo hump. Now why this redistribution of body fat occurs in with basically glucocorticoid therapy? This is because the peripheral tissues are less peripheral adipocytes in the extremities. They are less sensitive to insulin, but they are more sensitive to the growth hormone and glucagon or corticosteroid sensitive hormones. And as a result, there is protein breakdown, there is fat breakdown there, and leading to the basically loss of subcutaneous tissue in the extremities. But the truncal adipocytes, that in the trunk and the face and the neck, they are more sensitive to insulin and less sensitive to the corticosteroids. As a result, basically there is more fat deposition, there is more subcutaneous fat deposition in these tissues, leading to the redistribution of the fat. Now coming to calcium metabolism, number one, they increase the excretion of calcium from the intestine. They uh, they inhibit the calcium absorption from the intestine and increase the calcium excretion from the kidney. Number 2. Number 3, there is loss of osteoid formation and increased osteolysis in the bone, leading to negative calcium balance. Spongy bones are more affected, that include vertebra, ribs and the pelvis. Coming to the water excretion, now the effect on the water balance by the glucocorticoid, that is independent of the action on the sodium channel. In adrenal insufficiency, the capacity to excrete water load is decreased. As a result, the patients are in case of adrenal insufficiency, patients are more prone to water intoxication from intravenous fluid therapy. Glucocorticoids also enhance secretory activity of the renal tubules. Coming to the cardiovascular system, they decrease glucocorticoids, they decrease the capillary permeability, they maintain the arteriolar tone, and basically they also increase the myocardial contractility. The action on blood pressure is permissive. They facilitate the action of the pressure response of the adrenaline and angiotensin, and they should be cautiously used in hypertensive subjects. Now, in patients of adrenal insufficiency due to glucocorticoid deficiency, it leads to basically increased capillary permeability, arteriolar dilatation and poor vasoconstrictor response of adrenaline, leading to basically fall in blood pressure. Again, due to mineralocorticoid deficiency, there is basically hypovolemia, and ultimately combining these two, there is cardiovascular collapse in acute adrenal crisis. Coming to the skeletal muscle, they causes muscle weakness. Both hypercorticism and hypocorticism are responsible for muscle weakness. In basically hypocorticism, basically muscle weakness is caused by hypodynamic circulation. Now, in case of hypercorticism, it is caused by both glucocorticoid excess and mineralocorticoid excess. In glucocorticoid excess, basically there occurs muscle wasting due to increased protein breakdown and thus responsible for muscle weakness. And in due to mineralocorticoid excess, there is hypokalemia leading to muscle weakness. Coming to central nervous system, generally with pharmacological dose, there is mild euphoria. The Addison disease patient may suffer from apathy, depression and occasional psychosis. Now, the very important is that these glucocorticoids, they maintain the normal level of excitability of neurons, and in case of toxicity or higher dose of glucocorticoids can lower the seizure threshold. So, they should be cautiously used in patient of epileptics. Coming to stomach, they may aggravate peptic ulceration. Lymphoid tissues, action of glucocorticoids on the lymphoid tissues and the blood cells. They basically cause a rapid destruction of lymphoid cells. T cells are particularly involved than the B cells. This action is moderate in case of normal cells, but it is very important, or basically it is more marked in the malignant lymphatic cells, and hence it is for this reason that glucocorticoids are used in lymphoma. Now again, glucocorticoid, they increase the number of RBCs, platelet and neutrophils in the blood, and they decrease the level of lymphocytes, eosinophils and basophils, and the count returns to normal within 24 hours of stoppage of therapy. Coming to inflammatory response, irrespective of the type of the injury or the insult or disease, they suppress all stages of inflammation they basically suppress all components and stages of inflammation. How? They basically decrease the capillary permeability, they increase the arteriolar tone, local exudation is impaired, cellular infiltration is impaired, decrease in phagocytic activity of the recruited cells, and late responses like capillary proliferation, collagen deposition, fibroblastic activity, finally scar formation, they are all impaired. This action is direct and can be restricted to a local site by topical application. Now, they are basically it acts as an anti-inflammatory at various stages of inflammation. The important one being limitation of recruitment of inflammatory cells, number one, and decrease in the synthesis and release of pro-inflammatory mediators like prostaglandin, leukotrienes, platelet activating factor. Now, injudicious use of glucocorticoid can be hazardous. Why? Number one, they are only palliative. When used in inflammation, they are not altering the course of disease. They are only dampening the manifestation of the disease. As a result, although the symptoms are suppressed, the disease may progress and hence can be hazardous. Number one. Number two, they favor the spread of infection because the capacity of the defensive cells to kill microorganisms is impaired. Number three, they basically decrease or they interfere with healing and scar formation. And finally, peptic ulcer may be perforated asymptomatically. Now, immunological and allergic response. These glucocorticoids, they suppress all types of immunological and allergic phenomena. At therapeutic dose, impairment of antibody production or complement function is not that effective, and mainly that are manifested by suppression of recruitment of leukocytes at the site of contact with antigen and inflammatory response to the immunological injury. Cell mediated immunity are mainly suppressed, in which T cells are primarily involved, and so that particularly delayed hypersensitivity and graft rejection, and so they are used in autoimmune disease and organ transplantation. Now, mechanism of action of glucocorticoids at the cellular level. কিভাবে কাজ করে? Mechanism of action of corticosteroid. Anyone? Mechanism of action of steroid. Receptor কোথায় থাকে? At the membrane, at the cytoplasm, at the nucleus. Nucleus এ থাকে? No. First of all, they enter the cell. In the cytoplasm, they combine with a protein. This glucocorticoid receptor complex alters the structure of the complex and they facilitate the entry of the complex in the nucleus. In the nucleus, they combine with the glucocorticoid responsive element in the DNA and facilitate the formation of specific mRNA so that regulatory proteins can be synthesized. As most of the action of glucocorticoid are due to the synthesis of regulatory proteins. So, there is latency in the onset of action of glucocorticoid around 30 to 60 minutes. So, the effect is not immediate, but the effect lasts longer even after the steroid is removed from the body. In many tissues, the overall effect is catabolic, that is inhibition of protein synthesis. Now, these are some of the gene mediated cellular action of glucocorticoid. I will take few of them. Number one, we know that glucocorticoid, they decrease the glucose uptake and utilization in the peripheral tissues, that is mediated by translocation of glucose receptor in the cells from plasma membrane to the deeper tissues. Number two, they cause increased production of glucose from the amino acids, that is due to inhibition of hepatic gluconeogenetic enzyme, induction of. Glucocorticoid receptors are widely distributed. Some actions of corticoids occur instantaneously or are exerted more rapidly because they are not linked to the protein synthesis mechanism. Maybe they are linked to the receptor located in the membrane, like inhibition of ACTH release from the pituitary. All natural and synthetic glucocorticoids, they are effective by the oral route except DOCA, desoxycorticosterone acetate is a mineralocorticoid. It is a synthetic mineralocorticoid. They can also be absorbed topically, but the extent of absorption will depend on the site of application, on the compound that is particularly used, on the area of use and use of occlusive dressing. There are some water soluble esters like hydrocortisone hemisuccinate and dexamethasone sodium phosphate that can be given intravenously as well as intramuscularly, and they achieve higher concentration in the tissue. There are some insoluble esters like hydrocortisone acetate, triamcinolone that cannot be given intravenously as they are insoluble, and they can be given intramuscularly or even intraarticularly. Hydrocortisone undergoes high first pass metabolism. Now hydrocortisone is 90% bound to plasma proteins. It binds to a protein called transcortin. Now this transcortin protein is higher in pregnancy and with the use of oral contraceptive pills. Now as a result, in pregnancy and with the use of oral contraceptive pills, the level of cortisol may be higher, but free cortisol level is normal. The half-life of hydrocortisone is 1.5 hours, but the biological half-life is higher. Now coming to the synthetic, natural and synthetic corticoids. They can be broadly classified into glucocorticoid and mineralocorticoid. Now these glucocorticoids can be again subdivided into short acting, that is half-life less than 12 hours, can be intermediate acting, that is half-life between 12 to 36 hours, and can be long acting, that is half-life between 36 to 72 hours. Okay. Now coming to short acting glucocorticoid, only one is there, hydrocortisone is a naturally endogenously produced glucocorticoid. Now when we see glucocorticoid, we always see what the glucocorticoid is to mineralocorticoid ratio. Every glucocorticoid, they have got except few, they have got some mineralocorticoid activity. Now with hydrocortisone, the glucocorticoid is to mineralocorticoid ratio is 1:1. Coming to intermediate acting, they include prednisolone, they include methylprednisolone, triamcinolone and deflazacort. The glucocorticoid mineralocorticoid ratio with prednisolone is 4:1.8, methylprednisolone 5:0.5, triamcinolone, these have got no mineralocorticoid activity. The ratio is 5:0. Deflazacort, no mineralocorticoid activity, is 3:4:0. Coming to longer acting, there are two drugs, dexamethasone, betamethasone. They have got no mineralocorticoid activity. The ratio is 25:0 for each. Coming to mineralocorticoids, the endogenously produced mineralocorticoid is aldosterone, and the synthetic ones are DOCA and fludrocortisone. Now coming to hydrocortisone, is an endogenously produced glucocorticoid having glucocorticoid is to mineralocorticoid ratio 1:1. It is short acting, half-life around, plasma half-life around 1.5 hours. It acts rapidly but has got short duration of action. Now where is hydrocortisone used? It can be used in replacement therapy in patients of chronic adrenal insufficiency. The dose, basically we divide the dose in two parts. In the morning 2/3 of the dose is given and in the evening 1/3 of the dose is given. This is to basically simulate normal physiological cortisol level in the blood, so that there is lesser hypothalamic pituitary axis suppression. So, number 1, it is used as a replacement therapy in chronic adrenal insufficiency. It can be used in emergency setting because action is rapid. In shock patient, in status asthmaticus patient, and in case of acute adrenal insufficiency or acute adrenal crisis, where the doses are 100 milligram IV bolus followed by 100 milligram IV in 8-hourly infusion. It can also be used topically in skin disease or as a suspension for enema in ulcerative colitis. Coming to prednisolone, it is a synthetic glucocorticoid. Now, it is 4 times more potent than hydrocortisone. It is more glucocorticoid selective. Fluid retention occurs at high dose. Now, it has got intermediate duration of action between 12 to 36 hours. Now, it causes lesser suppression of pituitary adrenal axis, particularly when it is given once daily in the morning or alternate dose regimen is used. It can be used for allergic, inflammatory, autoimmune disease and in case of malignancy. Methylprednisolone is a slightly more potent, more selective than prednisolone. It has been used as a retention enema in ulcerative colitis, and pulse therapy of methylprednisolone is also used in non-responsive active rheumatoid arthritis, renal transplant, pemphigus. Triamcinolone, now it's again a intermediate acting glucocorticoid, slightly more potent than prednisolone and highly selective glucocorticoid. Now it can be used intra-articularly even. Coming to dexamethasone, dexamethasone and betamethasone, they are long acting synthetic glucocorticoid having plasma half-life between 36 to 72 hours. Now these are mainly used for number 1 in case of to induce lung maturity in premature infant, number 1, and number 2 in case of basically cerebral edema caused by the neoplastic cerebral disease. Now deflazacort basically is a synthetic glucocorticoid having zero mineralocorticoid activity. It has got fewer side effects and they are particularly useful in pediatric subject. Desoxycorticosterone is a mineralocorticoid having only mineralocorticoid activity 0:100, used occasionally for replacement therapy in Addison's disease. Fludrocortisone, it is mainly used for replacement therapy in Addison's disease, dose is 50 to 200 microgram daily. It can also be used in congenital adrenal hyperplasia and in case of idiopathic postural hypotension. Aldosterone is the most potent endogenously produced mineralocorticoid. It is not used clinically because of lower oral bioavailability and difficult to titrate the dose.